Everyone, welcome to this episode of the podcast. Sean Brewster, Bodine Ledden here with you today. Bo, we're going to talk knees and in particular, patellofemoral pain syndrome, a really common one. You see a lot of these in clinic?
Yeah, well, we talk about patellofemoral pain syndrome, and often people will come in and say, I've got runner's knee, or I've got non-specific knee pain, or I've got another label that fits under that umbrella. So
Yeah.
it's a bit of a I guess it's one of those areas that are called all sorts of different names.
It's really gone through a genesis over time, the different names. Like most pathologies, musculoskeletal pathologies, we see that the names seem to change about every 10 or 15 years. And it's interesting, if you watch that progression, the names are getting less and less specific and more general. I remember when I first started learning about this, it was called chondromalacia patelli, which is a very specific condition of the softening of the posterior surface of the chondral bone on the patella. It's like that's the cause of the pain every time. Well, maybe not. Maybe like runner's knee was another one. And we have patella tracking disorder or disease, I've heard it called. Now with patellofemoral pain syndrome. And then I've even heard it called just anterior knee pain, which is quite a common use of the term as well. So less and less specific, which tells us that we don't really know a lot of the time about the source of the pain. We know that it's somewhere in the front of the knee, and often people will point to the patella and the way it moves as the source of that pain.
Oh, so you're telling me that it's not the VMO that's not firing?
Well, Bo, I feel like there's a little sarcasm in your voice there. For anyone who's watching this on the video rather than the audio version, Bo has a big smile on his face. Yeah, it's possibly not the VMO's fault for everything uh, that goes wrong in the body. Yeah.
That's a classic one, isn't it? That the old school treatment strategy for it, like you said, with chondromalacia patella or patella tracking, it was roll out your lateralis
Mhm.
and do your end range knee extension exercises to fire your VMO because it's not firing. Um,
Hey, if you're a student of mine about 15 to 20 years ago, I'm sorry, because I think I gave that advice many times in many classes, and probably along with maybe Bo in the early start of his career, part of his career gave similar advice. I don't know, but it's
we've
evolved from
all
that,
done
hasn't
it.
it? Yeah, we've all done it. But it's funny, we just mentioned this before, but a lot of people will take that advice from the old school thinking and still seem to get results. What do you reckon the source of the results are then if it's not that?
Well, do you know, it's a good question. It could be just the natural regression of it could be decreased just sensitivity, getting people moving. It could be a number of things, but a classic old intervention that was often coupled with treat the lateralis and strengthen the VMO was the old McConnell taping. Right, you
Mhm.
remember, so where you'd sort of drag that patella in a medial direction, and that often had significant decreases in pain. And
Yeah.
so when we look at just modulating pain, decreasing pain in the short term, well, that could be performed with manual therapy, with mobilization. It can be performed with tape. Um, so yeah, I mean, when we look at why people get results, well, I mean, it could be from a number of things, but it's very difficult to just point the finger at a tight lateralis and a weak VMO.
Absolutely. And it's funny, we talk about these similar principles all the time with different presentations from our view on manual therapy, which is if you provide some positive sensation to the tissue in the area, some sensation that feels nice to the patient or feels like it's therapeutic in some way, then that will help to modulate pain through gating the pain and other pathways. And then if do some exercise, end range knee extensions, for example, and you get a little bit more strength in the region, well, there's two key concepts that do hold true. Preferred sensation will beat out non-preferred sensation usually, at least temporarily, and then exercise to strengthen the area will move you through the progression of rehabilitation faster. So while those two very specific approaches might be flawed in their thinking, the outcome seems to help. But if we take those concepts and sort of peel them back, you can do probably anything to strengthen the quadriceps and it'll get you to the same place. And you can probably do just about anything with manual therapy and you'll probably get to the same place. So it simplifies things a lot for us when you think about it like that.
Yeah, that's right. But I think it's like you said, it's strengthening the quadriceps, not strengthening a single muscle within that quadricep group, which is impossible. So when we're strengthening the quadriceps, all of the quadriceps are being strengthened. And so, yeah, it's just about providing a stimulus that allows adaptation and then it's progression from there. I mean, but if you just stuck with end range knee extension or a wall sit, you know, throughout the duration of your rehabilitation and never progress beyond that, then yeah, well, it's probably not going to get a whole lot better. Or if it does, it could just be because it got better and
That's
not
right.
because of
Yeah.
the specific intervention.
It's really hard to know. And, people will come in and see you and, for a second opinion, or just maybe they've just found themselves in your clinic and they'll say, oh, such and such used to treat me for this with this approach. And it's an outdated approach in our eyes. It seemed to work all the time. Like, you're telling me that that's no good, but it worked. I'm like, yeah, okay, cool. We can just move on. It probably worked for different reasons than maybe they were thinking. But those mechanisms of effect are the same. We just need to probably look a little broader and see more options than saying it's just this thing.
Yeah, for sure. So we've gone through a little bit of the myths and misconceptions. So talk us a little bit more through, what causes it, and maybe even the types of symptoms that patients will experience.
I'll start with the classic symptoms and then go to the potential the different causes that we might have. So classically, and I've had this condition myself many times, being a runner and doing other sort of athletic things over the years. And the classic presentation is very severe, sharp stabbing pain at the patella, or usually medial and inferior to the patella, but it can vary. And the knee can buckle, can give way in those moments. It typically aches at rest if you're seated with a flex knee. And so the explanation for that is usually it's increased compression of the patella against the trochlears of the femur as they're sitting in a seated position. So tension on the quads dragging the patella against. This is the thinking. So you'll have aching knees at rest. On extension of the knee, you'll often get a click. So that compression might create some like a load through that joint. As you open it, it sort of pops like you would see at any joint that can kind of crack and pop. Usually more painful going downhill. So the eccentric load through quadriceps at that downward angle is higher. So that the load and compression is higher and therefore the irritation's higher. But just upon squatting, it's usually the first few degrees of flexion where you get it the most. And at the end range of extension, the end range of flexion, it might be sore again because you've got maximal compression and load through the joint. And then it comes and goes. This is the frustrating thing about it. People come and say, it's been bothering me all week, and now I've walked into your clinic, I can't make it come on. And so that's why we have different orthopedic tests that will kind of increase load on the joint and try to replicate it. But a lot of those tests are excessively sensitive and they just set off everybody, even non-symptomatic people. So it can be a real challenge. But if we look at, I guess, two different categories of causes clinically, I'd break those down into pathological triggers. So something's wrong in the structure. And then load-based triggers, something's wrong in the way that we're moving or loading our body. Pathological trochlear dysplasia is one that's probably often overlooked, so that the shape of the end of your femur can vary, just like just about any bone in our body can vary. And I think that's one of the things that's often forgotten. We look for the functional causes or the obvious to the eye causes, but it could actually be a change in the shape of the bone that's predisposed the person to these issues. And then when they load it inappropriately, they get the problems. Laterally positioned tibial tuberosity. And you might have seen, I've seen a few people over the years that have had surgery to move that tibial tuberosity more medial so that you get an improved Q angle, on like a quadriceps angle and line of pull. An increase in Q angle during developmental phases, particularly on females, particularly as they go through puberty. So pelvis gets wider, knee to hip angle increases as your Q angle. And so this inability for the body to keep up with that change usually normalizes over time, but not always. Genu valgum, again, another structural anomaly at the knee. So just bowed knees, like knees in, knock knees, which again increases that Q angle load. Short, tight retinaculum. So dragging that patella into a laterally deviated or tilted position. That might be a result of some sort of trauma, or it might be just congenital. And then patellar dysplasia as well. So change in the facets of the patella and how they articulate with the condyles of the femur. So there's some pathological triggers potential.
Yeah, there's some interesting points there. And when we think about that, well, they're all Mostly a morphological changes. So, I mean, you've got a morphological variation and you're giving VMO exercises. You
Yeah. The patient gets better. So that tells you that your morphological changes may be a contributing factor, but they're not going to be the deciding factor on
know?
whether you can move forward with this presentation.
Yeah, and also understanding morphology is that can be normal for that person, and so it doesn't necessarily need to change. It could be the other modifiable factors that can change, and we can modify them as far as the amount of load, the intensity, the duration, the frequency, the type of activity. There's a number of different variables that can be modified. Um, but we've got to understand that morphology may be completely normal for that person. But yeah, it's certainly in some circumstances, other interventions are required.
That's right. Like our old favorite Bo with the old leg length discrepancy, and how that's the source of all evil on the planet. It's caused famines and floods and locust, plagues and everything everywhere, isn't it? The leg
And
length.
yeah, and pronation. I pronate.
Yeah, well, I hope you do, because we need to. It'd be really difficult to absorb shock without that. So these morphological and functional anomalies are normal. So we shouldn't really call them anomalies. They're normal for some people, and that person would have, in most cases, adapted quite well to that leg length discrepancy or that trochlear dysplasia over time. Um, and it doesn't have to equal pain. So when somebody presents with one of these morphological changes, probably a better term than pathological changes, morphological changes, and they suddenly have pain, well, then we've got to look at what else it is. Because you go and get a scan and, oh, yeah, the back of your patella is shaped differently than it should have been. Well, hang on a second, that didn't happen last week when my pain started. That's obviously happened over a long period of time. So, what are the other modifiable, what are the other functional factors that we can address and should address to get changes? So, that's in the management. So if we go into the next list, which is load-based triggers, which is really our, very much modifiable and very much, I think, probably more often the cause of these presentations, the things that we do rather than the things that we have. And so patella subluxation. So if somebody's subluxed or dislocated a patella, that can lead to laxity on the medial side of the patella. So the structures that would hold that down, the retinaculum and ligament so on, that would hold it there, creates a relative excessive tension on the lateral side. So now the patella is more likely to slip laterally. And then when you have things like an increased genu valgum or an increased Q angle or whatever, then now we find that patella drifting, potentially drifting more laterally than it should. And people get a lot of fear and apprehension around that.
Is that usually triggered from trauma though? Like if someone lands heavily on
Yep.
their knee? Okay.
Or a direct force to the patella, something sliding across it. Yeah. Yep. And so patella subluxations aren't usually congenital. They're not something you just tend to have happen unless you've got that really altered patella facet shape. So they've had an injury of some sort, and now they're getting patellofemoral pain as a result.
And if anyone has seen a patella dislocation, they're
Awesome.
pretty violent.
Yeah. Oh, you definitely notice that you've had it. Yeah. Um, can I tell a really funny story just quickly? This is sort of off topic, but I had a student years and years ago tell me about how when she dislocated her patella, she was about 17. She was at home. She just got out of the shower. She's in a bedroom moisturizing her legs, and she's completely naked. And the door swung open, and it was her dad who didn't realize that she was standing there naked. And she freaked out, fell over, dislocated her patella. Her dad screamed, freaked out as well, because he couldn't look at her because she's a 17-year-old girl, didn't want to give her privacy. But so he's got his back to her. She's screaming, saying, my knee, my knee. And he's like, what do you want me to do? I can't turn around. So you can imagine yourself in that situation. I picture myself as the dad just freaking out, running away and calling someone on the phone, can you come over? Because I can't help her. And she was crying out for help, but at the same time, didn't want him to help her. So there you go. That's a very good example of a traumatic patella subluxation. And she remembered that years and years and years later, obviously. So patella subluxation, sudden increase in load, and that's generic, I know, but they've been exercising and now they're doing way more than they were, or they were doing no exercise and now they're doing some. And so that's probably, in my experience clinically, the most common cause. Someone comes in, they've been running, now they're running way more than they were, now they're running downhill way more than they were. They're also squatting at the gym, they're also doing something else. Um, Arthrogenic inhibition of vastus medialis. Okay, stay with me on this one. There's research to support this. And while we talked before about vastus medialis weakness relative to vastus lateralis, and that theory being false or misleading or has a fault to it, there is evidence to suggest that when we get knee effusion, so swelling inside or fluid inside of the joint itself, the joint capsule, at least two studies that I've found have tracked that if you get between 20 and 30 mil of fluid inside that knee, effusion, the first thing that you'll note on functional change is a relative weakness of the vastus medialis, inhibition of the vastus medialis. At about 50 to 60 mil, we start to see inhibition of rectus femoris and vastus lateralis. So while we don't necessarily advocate for target VMO for your massage and target vastus lateralis and ITB and stuff, sorry, vastus medialis for exercise and lateral structures for soft tissue work, there is at least some notable change. When there's swelling in the knee, we get some neurological inhibition of vastus medialis before the others, which may account for, we don't know for sure, may account for some of that lateral movement of the patella, which then may account for some of the pain that happens due to that uneven positioning or less than ideal positioning of the patella. So there's a concept. What do you think of that?
Yeah, I haven't seen the literature on that so much, but I mean, when we look at any joint effusion or any injury where there's an inflammatory component, there is going to be some degree of inhibition to that area, no doubt. But I think that the problem is the narrative going forward.
Exactly.
So I think in the early stage, it's just about getting some movement, getting some strength, decreasing pain and decreasing inflammation, and then promoting general movement and general strength around that area, as opposed to focusing on a specific muscle.
Yeah, yeah. Look, I've had particularly runners who have had long-term patellofemoral pain syndrome, for want of a better term. We'll call it a syndrome because it's a collection of symptoms. We don't really know what the source of the pain is. And they've come in saying, hey, my right vastus medialis is not firing. I've been told this over and over again. And you look at the right versus the left, and there's a notable difference in muscle size. Like they've had it long enough to affect the muscle hypertrophy or the bulk of that muscle. And they've often complained of, or you can note swelling with it as well. So I don't know whether there's an obvious link there, but there is some literature that points to effusion causing inhibition of those muscles in that order. Now, if you get 20 to 30 mil for VM or 50 to 60 mil, there's not a big difference between the two as far as how much fluid's in that knee. And in most cases, you're probably going to be hitting 50 to 60 anyway, if you're going to get swelling in there. It's not a lot of fluid. So if one comes before the other, interesting, potentially useful. But if they're getting swelling at all, you sort of treat it as a whole and say, let's get rid of the swelling. That's going to cause some inhibition. Let's get rid of the swelling, manage that, and get you moving and improve your strength overall, I think is the advice we want to give to people.
Yeah, but how often in say your long-standing knee pain, chronic patellofemoral pain syndrome, will there be swelling?
How often will there be swelling?
Yeah, I mean, like if we're talking about swelling or a joint effusion, usually that's going to be in those more acute and subacute phases.
Yeah. So when I'm thinking of patients that have had this, they've had the problem, the presentation and the pain for, say, months. And then they'll have bouts of acute flare-ups. So they've pushed through the pain and now they're sore and the knee will actually feel swollen. They'll have limited range of motion, like that tight compressive feeling. And you can sometimes see, obviously, extracapsular fluid around the knee, and they feel like their knee is full. So I've seen that a few times, but it tends to be, like you said, an acute spike rather than long-standing effusion.
Yeah, and I think it's also important to when we consider that if we've got swelling, there's often an intra-articular driver behind that, and that's where we've got to look at. Well, in those chronic, long-standing cases, there's potentially and likely coexisting pathology around that area as well. It leads to increased levels of sensitivity and potentially more inhibition of muscles or limited function.
That's right. And so if I think back to one of these studies I was reading, it's quite a while ago now, but there wasn't an obvious link between the swelling and the patellofemoral syndrome as the source, but there was swelling, and then that resulted in muscle inhibition, which then the hypothesis is that might contribute to that problem. So it may that maybe they've got a meniscal tear or joint surface changes or something like that, arthritic changes that are then leading to the swelling. And then they develop the anterior knee pain as a result of that. That's the hypothesis, as a result of that swelling. So yeah, we can't look at that swelling, or we can't look at the weakness, potential weakness of that muscle and say it's because of the patellofemoral pain syndrome. The patellofemoral pain syndrome might be a symptom of inhibition, which might be a symptom of swelling, which might be a symptom of an arthrogenic problem in the knee. So there's a lot of potentials there, but that's where we have to kind of go with our diagnostics and our clinical thinking, is there's a potentially a lot of different parts to this puzzle.
Yeah, and also, if I didn't move my shoulder for a while and didn't put as much load through it, it would be the same as, if I had a painful shoulder, same as the knee. So you would likely expect to see some changes in cross-sectional area of these muscles, or, if we looked at EMG studies, um, but it could be due to less load going through there as opposed to just a particular muscle being switched off, I guess.
That's right. Yeah. So I think the moral to our story is there's a lot of theories, there's a lot of ideas, and there's a lot of clinical features that we would see with the patellofemoral pain presentation, and it will vary from person to person. And I think this is why it's one of those conditions that so many people get frustrated with, because it doesn't follow a very clear-cut path. Like you'll get this, then you'll get this, then you'll get this every time. It's a joint that you can't really help but load. If you're going to move around in the day at all, you're going to be loading it. And so the ability to rest it is pretty poor. And then you get given an exercise that might be potentially aggravating to that. They give you a squat or something that might be the wrong thing for you at that time. And now you're creating more compression and possibly more irritation and pain. So we see people go through this kind of windy trajectory in their recovery process a lot of the time. They get frustrated, then they don't do anything. They stop exercising. They sit on the couch and say, I'll just rest and won't do anything. They lose their strength and then head back to sport or activity again. And then they're basically just starting back at zero and building again, and ending up with the same problem again a few months later.
Yeah, I genuinely think that the knee can be one of the hardest areas to treat and to load and to rehab. It's just one of those joints that it undergoes so much load. It needs to be able to withstand multi-directional forces. It needs to be able to withstand end range movements. But it's one of those joints that can be highly sensitized. It can be highly irritable. And also the patient is often very apprehensive around movement of the knee, and particularly those end range movements and twisting movements.
Yeah. And it also explains along that line of thinking why we have so much research, so many people finding themselves as specialists or experts in the knee, because it's a big area, and it's like you said, it's a highly sensitive joint that presents a lot with any kind of athlete, or actually anyone that just moves through life. They're likely to have knee pain at some point. And so yeah, it's a big hole. It's
Yeah.
a very big hole.
Yeah, so I just want to go back to it. You spoke about the the potential, the symptoms and the potential cause of patellofemoral pain syndrome, but I think it's worthwhile discussing some of the differentials around that area. Because when we look at anterior knee pain, well, there's a lot more things that could be going on there.
Yep.
What like do you have a bit of a list of differentials there?
Yeah, off the top of my head, well, it's firstly an anterior knee pain diagnosis or term is probably a better one to use for that reason. Is people come in with what we think is PFPS, and it could be retropatellar bursitis, pain against the from the bursa at the patella. It could be an inferior fat pad contusion or a fat pad compression due to a tilted patella or hyperextended knee pincering and compressing the fat pad. We could have really simple stuff like just referred pain, referred myofascial pain, like the rec fem trigger point referral. Classic trigger point referral goes right over the top of the patella. At least one of the trigger point regions does. So there's that as well. We've got to look at ligament and meniscus and other joint related causes of or sources of pain as well. There's a whole stack of stuff, and so retinaculum strains. We can have what else have we got in the region? Look, there's a bunch of things. They're the things that sort of come to mind, I guess. Basically, any structure in the knee can be a source of pain, and a lot of them are at the front. So it gives you a lot of options.
Yeah, and you mentioned the fat pad. The fat pad is the most highly innervated structure in the
Mm.
knee, and it's much bigger than sort of what's represented on a lot of images. So it is important to differentiate the fat pad, which will sit, I guess you can palpate either side of the patella if it's most sensitive there, and particularly when they're moving into end range knee extension, but also differentiating that from a patella tendinopathy, particularly an inferior patellar tendinopathy. So that's often going to be patients will describe that that's also worse, running down hills or under load. It might be worse first thing in the morning. It's going to be worse, rising from a chair or even going into a deep stretch. So palpation directly over that patellar tendon and getting them to, forcefully contract into knee extension against resistance. That's important to differentiate if there's a patella tendon based problem.
Yep.
So you mentioned the fat pad. What else we got? If we look at, as you said, um, even like further down and more medially, like you could look at the pes anserine, often pes anserine bursitis. So using your palpation and going through these structures are important. As far as ligamentous structures around the knee, um, the knee's relatively simple when you think of the structural support there. You've got your medial and lateral collaterals, and then your ACL and your PCL. You've got your patellofemoral ligaments as well. So structurally, as far as ligaments go, that's pretty much it.
Yeah.
And then you've got your biceps fem that's going to attach down onto the head of the fib, and then medially semi-ten, you're going to have gracilis and the sartorius attaching right onto that pes anserine. So palpating all of through those areas to rule them out, and doing some testing is important. You're palpating around the joint line for the medial meniscus as well, and the lateral meniscus. Um, Even looking at some hamstring strength testing as well. You've got to consider those hamstring tendons. So going through that structural screen and then looking at the patellofemoral joint as well. So there's a few things to go through there, and there's a lot of structures that can become sensitized around the knee.
Definitely. And you're spot on with the palpation. You can learn so much with palpation around the joint, around the knee itself. All these structures are, except for the ligaments and meniscus and things, except for the edge of the meniscus, I should say, very much superficial. We can palpate a lot of those. And I think you're right about the inferior patellar fat pad compression as a very obvious source of pain a lot of the time. I think that one gets overlooked. And so your advice to palpate the patellar tendon, you just literally slip off the sides of that and press in next to it, and you're directly over that fat pad. And it is, yeah, you're right, the most highly innervated structure in the knee, super sensitive. And if you've ever irritated it before, you'll know about it because as soon as you move into that end range extension, you get a swollen, inflamed, irritated fat pad occupying more space than it should, now getting compressed. And the classic test is just hyperextension of the knee. Just push their knee into hyperextension. Does it hurt in the front of the knee? Well, unless it's a torn ligament, it's very likely to be a fat pad compression. And so, yeah, that's great advice. And a lot of the time, too, the symptoms that the person will feel are transient. Like they'll get it at times and not at others. And so your assessment can be misleading as well because they might have walked in and that inflamed bursa, fat pad, whatever has settled. We can't replicate the problem, can't replicate the pain. And then they go out and run down a hill again or hyperextend it again and their problem's back. And so it can be quite difficult. So your history is really important. Asking about mechanisms, what happened at the time? What were you doing at the time that the pain come on? Were you doing a lot of repetitions of something in the lead up to it? Were you doing hill sprints or something? Was there a moment in time, or what were you doing in the minutes leading up to that source of or the start of that pain? And see if there's some kind of pattern. And then you do your assessment, you do your palpation and so on, and try to work backwards from there. But it can be a tricky one for sure.
Yeah. And I just wanted to add in, obviously, when we talk about exercise and loading it, if I was bagging those end range knee extensions before, I've got to give you something else to do. So, if we're trying to put some load through that area, I mean, you can start with some isometrics in knee extension or a wall sit, and that's fine, but it's got to progress from there. So ideally, just looking for a movement that is, I guess, uncomfortable for them to do. So if that's moving into a squat, trying to find a way that to make that more comfortable. So if it's, let's say they get discomfort or pain at 90 degrees of a squat, 90 degrees of knee flexion. Well, let's take them only to 80 degrees and work from there. And, having them sit to stand, something like that is better than just doing a end range knee extension. That could then be progressed to single leg. It could be progressed to a split stance. And the modifiable variables that we're looking at here is the depth that they're going to. So keeping them in relative a movement that's not necessarily provocative, but a little bit of pain is okay. So it could be the depth or the range of movement that they're going to. It could be the amount of repetitions. So if it's uncomfortable doing 10, do 5. And then it's just about progressing them from there. But we've got to provide a stimulus that's heavy enough that will stimulate some adaptation. So don't be afraid to load them up, but don't just look at the quads, look at the hamstrings, look at the calves, look at the hips. And that's why I think, I guess, that's really my personal opinion about the specific end range knee extension isolation exercises, because we've got to address that whole kinetic chain. And so getting them back to doing some more functional movements, such as a bodyweight squat or a split squat, is going to be far more beneficial, particularly if their goal is to get back to the gym or get back running or running up hills or whatever that may be. So I think the important thing here is to identify, what are your goals? What do you want to get back to doing? What can you do now? And let's work within those limits and start to progressively increase that over time.
Yeah, 100%. And then coming back to that point you just said about what can you do now? It may be that you've got someone whose knee is so sensitive and they're so apprehensive and fearful of movement, and anything more than 30 degrees, 20 degrees of flexion is really uncomfortable for them. It might be that end range knee extensions is where you start, but not for the reason that we originally thought. It's not because we're trying to just isolate VMO. We don't have to turn that leg out slightly and, elevate that knee to get that targeted muscle activation. It's because that's some muscle activation that they can do now. So what could you do? What would you do? What will you do? And that's where you can begin. It might just be that. And it might be unweighted. It might be just the weight of their foot. Then we add some load, and then we progress to some more range, and then they're squatting, and then they're lunging, and then they're jumping, and then it'd be built up from there over time.
Yeah, and from a manual therapy point of view, that's where manual therapy can be so beneficial in these phases. As you said, someone that's highly sensitized. Well, it might be that it's just going into a little bit of a squat that causes pain. Well, what if you apply a medial glide to the patella and then get them to perform that movement? Does that modify their symptoms? If they can do that easier, well, let's do that a few times. Let's get you a bit more comfortable with that movement. And then that's where tape can be so helpful in this stage, right? Well, let's tape it. And that's the classic old McConnell tape. And it may not always be in a medial direction. It could be that you need to provide a superior glide or an inferior glide, lateral glide. It's whatever, I guess, stimulus decreases their symptoms and allows them a greater range of movement for a period of time. Because if that allows them to move with less pain, then that's that window of opportunity that we've got to strengthen them up and get them back to those meaningful activities.
Yeah, that's right. And I think that's probably the biggest shift in the way we're thinking about manual therapy and exercise and stuff recently, is this, rather than focus on specifics or the specificity of a direction of movement or force, a direction of load with what we're applying clinically, it's about what seems to work, what seems to make them more comfortable, and then how can we replicate that? How can we make that a part of your existence? So like you're saying, we might medially glide the patella and then we tape it, or we might inferiorly glide the patella and then we tape it. And this goes for anything, right? It doesn't really matter. So we used to think that, an anterior pelvic tilt will lead to this, this, and this. But maybe if we sort of rotate that patella, pelvis posteriorly, and you feel like you can move better, well, we should tape you in a posterior tilt position. Even if that goes in the face of what the clinical reasoning was, is what feels better, which will create that window of opportunity so that you'll want to move and that you will move. And then when you are moving, there you've got something to build on. It's a scaffold. Like if you just hold tight and don't move because you're afraid, well, you've got nowhere to go. So all we're doing as manual therapists, and this is what we're trying to preach here, I think, is simplify. Like just keep it as simple as possible. create an opportunity for someone to feel better for a moment in time. And then when they feel better, you're not finished. The next thing is now have them do something with that, whether that's a knee, a shoulder, a neck, have them do something with that. And when they build their confidence and their competence with that, then we see how we can get them to the next bit, the next bit, and the next bit. And then we step back and let them go. And our job is done.
100%.
100%. Is that the end of our chat today, Bo? We finished?
I reckon we'll wind it up. I don't know how long we've been going for, but we could probably keep going.
I'm finished preaching. How about you? All right. We'll call that a day. Thanks, guys, for listening. We'll see you on the next one.
Cheers.